Okay, so welcome all listening to this lecture. Um, so we're going to really wrap up the discussion that we're going to have, at least in this series, about our obstetrical patients with hypertensive disorders in pregnancy. So for those who have began the uh, clinical modules here at St. John's Episcopal Hospital on labor and delivery and in clinic, you'll appreciate that our population has a great prevalence of hypertensive disorders in pregnancy. And in fact, hypertensive disorders in pregnancy is a clinical scenario that remains a challenge for the larger obstetric population throughout the country. And like other hypertensive disorders, a lot of times they are clinically silent until they reach a critical point. Um, so it's very important to be actively looking for the development of hypertension in pregnancy as you follow patients in prenatal clinic, especially if they have risk factors, and then in general, managing it in a very prudent manner. I'm not going to say aggressive, but a prudent manner. And that's largely dependent on the diagnosis that you make. Hypertensive disorders are best understood as a spectrum of disease, as opposed to discrete entities, as I'll describe. You'll start with simple hypertension and no other issues, which is gestational hypertension. And the pathogenesis is such that if gestational hypertension is diagnosed and untreated, then it will progress to preeclampsia without severe features, with severe features, HELP syndrome in its most severe form. So that's why in ACOG, for example, and then just general practice will recommend induction of labor at earlier stages of term, say as early as 37 weeks, which is the threshold of a term pregnancy, because of this fact, as we'll get into. So hypertension, either pre-existing or pregnancy-induced, is a common complication of pregnancy that ranges from the beginning of pregnancy to 6 weeks postpartum. So you may be confused to say, well, how is hypertension occurring in the postpartum period after a fetus is delivered? Because a lot of what I'll tell you is the definitive treatment for preeclampsia and eclampsia, HELP syndrome, etc., is delivery of the fetus. Well, the way you want to think about this is almost analogous to if a toxin is released. We know that the placenta is implicated in the pathogenesis of preeclampsia and development of pregnancy-induced hypertension, as is most of the pregnancy-induced syndromes, such like gestational diabetes. But it's thought anyway that like some sort of insult, you could think of it as a toxin or a mediator, is released from the placenta. So even after the placenta and the fetus are delivered, that substance hangs out for around 6 weeks postpartum. So this spectrum of disease can actually have its initial presentation in the postpartum period. So that's important to highlight. But we care about hypertensive disorders in pregnancy because when it's severe, it can lead to stroke and death, as can any severe hypertensive disorder, okay? The difference is in pregnancy-induced hypertension, when you get into diseases like preeclampsia, it could lead to eclampsia, which is seizure activity, which is not a feature of hypertension in a non-pregnant patient, because the physiology and the pathophysiology of preeclampsia involves a spasticity of the blood vessels, right? So they'll spasm, and that will lead to a seizure as well, as opposed to just simple hypertension, where severe hypertension then leads to stroke and infarction in that way, like hemorrhagic stroke. So, but to start out in our discussion about pregnancy-induced hypertension, terminology is very important. So we'll get into the terms gestational hypertension, preeclampsia with or without severe features, eclampsia, HELP syndrome, and these represent a spectrum of disease from mild progressing to most severe. Acute fatty liver disease in pregnancy is related to this discussion in that it presents with hypertension, but a couple of other features. This acute fatty liver disease is a very severe manifestation where you have acute fatty change to the liver and essentially puts a patient into liver failure in an acute setting. So this carries a mortality risk and the patients are very, very sick. Something to keep in mind we'll get into. And then you have chronic hypertension, which in the obstetrics and gynecology world, chronic hypertension is the analogy to essential hypertension. But this is a discrete entity from your hypertensive spectrum. And as such, you can have both chronic hypertension and the development of preeclampsia. When this happens, it's called superimposed preeclampsia. And we'll get into the nuances of how this situation occurs. But to say it, at least to introduce the subject, chronic hypertension is one definition, and preeclampsia is another. When both criteria are satisfied, you have chronic hypertension with superimposed preeclampsia, which we'll get into. At any point, if you have a question, feel free to interrupt me or write in the chat box, okay? So let's first clarify our terminology. Important to remember for all of you who may have been on your primary care rotations, etc. In the obstetrics world, hypertension is defined as, it starts anyway, as blood pressure of 140 systolic or a diastolic blood pressure of 90 millimeters of mercury, okay? And to have a diagnosis of hypertension, you need at least 2 occasions, at least 4 hours apart, after 20 weeks gestational age. From our prior discussion about obstetric hemorrhage, remember that after 20 weeks, that's when fetal viability is established, and fetal viability is really established around like 23 weeks is the threshold of viability. But after 20 weeks, that's when a pregnancy no longer qualifies as a termination of pregnancy, no longer constitutes a miscarriage, but is actually a fetal loss, okay? So 20 weeks gestation is a good number to keep in the back of your mind. So in terms of hypertension, it starts at 140 systolic and or 90 diastolic. You'll hear that commonly referred to as something called mild range pressure. So your mild, if they'll say, oh, the patient has mild range pressures, that's talking about 140 to 159 systolic and 90 to 109 diastolic, because severe range for blood pressure for us is 160 systolic, 110 diastolic, okay? There's no pre-hypertension in obstetrics. It's just either hypertension or not, and mild or severe. Mild being and severe being the definitions that I've given you, okay? With severe hypertension, you don't need 2 occasions 4 hours apart. It's really just an interval of 15 minutes. If you have a severe range blood pressure, you repeat it in 15 minutes. If it's still severe, you make the diagnosis of severe hypertension, and then you act in the way that I'll describe, okay? So gestational hypertension, by definition, it's hypertension without proteinuria or severe features and develops after 20 weeks of gestation, okay? That's the bottom line in terms of the definition. When you have any severe features, which we'll explain what those are, or if you have proteinuria, it ceases to be gestational hypertension, and then it's preeclampsia, either if with or without severe features, depending on that definition. Okay, and really, patients, the way they'll present, they won't have any symptoms. They'll feel fine otherwise, but we'll say, hey, well, we notice that your blood pressure is elevated, and you could make that determination either 2 occasions 4 hours apart, or more practically, if you follow them in the prenatal clinic, you'll know you get their vitals at that time. So you'll know that the vitals are, that their vital signs were otherwise having normal blood pressures, normotensive, and then all of a sudden it's elevated, you make your diagnosis. The outcomes for gestational hypertension, in terms of obstetric outcomes for mother and baby are usually good. Usually, the hardest part is to really just identify it. Um, it's it's important to highlight again that gestational hypertension is not a discrete entity. It's just the beginning of the development of more severe hypertensive disorders. So if you catch it in the beginning and the treatment being induction of labor, um, the outcomes are good. But what's important to remember about gestational hypertension as well is that up to 50% of women um, will develop proteinuria and end organ dysfunction consistent with preeclampsia if you let them. And then that progression will happen faster if you diagnose gestational hypertension before 32 weeks. So that's pretty uncommon to see hypertension develop before 32 weeks gestation. I told you it's after 20 weeks by definition, and that's so, but usually we see that in the late third trimester. You'll see hypertension develop maybe at like 36, 37 weeks, and that's like your normal gestational hypertension that will have a benign outcome. If for some reason you're identifying that, say in the late second or early third trimester, um, the progression is faster, which means you usually get to something like HELP syndrome more quickly if you're not watching it. And remember, our prenatal appointments, they get closer together when you get past, say, 36 weeks. It's every week. At 32 weeks, if you had missed a diagnosis of gestational hypertension, you may not see that patient until 3 weeks later. So at which point you would have missed that progression. So this is why it matters. Um, so gestational hypertension, in summary, hypertension without any other associated laboratory findings, which we'll get into, and there's no proteinuria, and otherwise no other symptoms. So preeclampsia with and without severe features is the next step in this. Okay, preeclampsia is distinguished from gestational hypertension in that it presents with signs of end organ dysfunction, okay, with organ dysfunction. And that's manifested through certain laboratory criteria in addition to clinical symptoms. So there was the prior definition of gestational hypertension also included if you had severe range blood pressure, you could have something called severe gestational hypertension, meaning that there was no proteinuria or any other lab findings, but you had severe range blood pressure. So older text may refer to that, but as of 2020, ACOG has revised its practice bulletins, and the definition has changed really that gestational hypertension it does not involve severe blood pressures. Okay, if you have severe blood pressures at all, you are dealing with preeclampsia with severe features. So the way you want to think about it is that if severe blood pressure is there, it's a severe feature. So you're no longer dealing with gestational hypertension. So make sure that you're reading recent foundational material as well, so you don't get confused. But preeclampsia without severe features is really your next step from, so you have gestational hypertension, and then in the pathway, you have preeclampsia without severe features, okay? Sometimes this is how you'll see it abbreviated, without severe features. So the only difference between gestational hypertension and preeclampsia without severe features is simply the presence of proteinuria, okay? You're going to have mild range blood pressures, so 140 to 159 systolic and or 90 to 109 diastolic, and you'll have positive proteinuria. In the past, there was a distinction between like proteinuria that was mild, which was 300 milligrams, I believe, and then 600 milligrams when it was severe. If you have proteinuria at all, that's above 300 milligrams on a 24-hour urine protein, above 300, then that counts as significant proteinuria. Also, what's largely used these days is something called a PC ratio, which is a protein creatinine ratio, and the threshold for that to be positive in our context is 0.3. So 300 milligrams, 0.3, that's how you know. So preeclampsia without severe features simply is mild range blood pressures with proteinuria. If you have any severe feature, so severe hypertension, if you have um, any of these lab values that I'll mention, you're dealing with preeclampsia with severe features. And the reason why they changed that definition is because of the way it's managed, which I'll get into the subtlety of that. But what was happening is that severe gestational hypertension, quote unquote, and preeclampsia with severe features, they were being managed similarly in you needed to administer IV antihypertensives and also magnesium sulfate for seizure prophylaxis because you still had a risk of having a seizure with severe gestational hypertension. And some people weren't give magnesium in the context of severe hypertension, and then people ended up seizing. So in order to make it simpler and from a standpoint of management and safety, that's why that change was made. Okay, so preeclampsia with severe features can be diagnosed on the context of severe blood pressures in and of themselves, or the following. So preeclampsia with severe features, you can have mild range blood pressures, and any one of these lab abnormalities, and it counts. So one is thrombocytopenia. So you get your CBC, and if your platelet count is 100,000 or less on the CBC 100, you'll see, or less, that's a severe feature. Okay, suggestive of a platelet dysfunction. If you have impaired liver function, in which case you would have either twice the upper limit of normal for the AST/ALT or double the baseline if you have a baseline of a patient, okay? And that's indicative of liver dysfunction. That could be this. You don't need both for preeclampsia with severe features. You just need one. If you have mild range blood pressure, if you have severe range blood pressure, you don't need any of these. It's still preeclampsia with severe features, right? So if you have serum creatinine concentration of greater than 1.1, that's a severe feature, or if it doubles from baseline. And that's suggestive of renal dysfunction in the context, that's a severe feature. Then you have other sort of, you have clinical things. For example, severe persistent right upper quadrant pain. This is something that's actually fairly significant because it's reflective of edema and stretching of the outer capsule of the liver, which is called Glisson's capsule. I'll skip to that. So this symptom develops the right upper quadrant and epigastric pain because this is becoming edematous because of preeclampsia with severe features, okay? And this is not a theoretical thing. What sometimes can happen in cases of preeclampsia with severe features is that usually it's in cases that progress to HELP syndrome. Uh, the capsule could be so edematous and stretched so much that you actually get hemorrhage. This is an example of a CT scan showing a capsular hemorrhage in the context of preeclampsia with severe features. So that right upper quadrant pain and epigastric pain is reflective of this. And anecdotally, I'll tell you that in residency, I did see a case where there was a really bad liver capsule rupture and hemorrhage. We had to transfer her to an ICU for a while. And so this is something that does happen, but usually it happens in the context of HELP syndrome, as the main presenting symptom is right upper quadrant pain. Uh, and I actually had a case here at this institution not too long ago. The patient's main complaint was that she's like, I got pain here up in my chest and it's bad, it's not going away. And the ironic part was that she's like, I went to my doctor and they told me that it was fine, but really she was 28 weeks. So, and we did all of these labs and all of them were abnormal, which is, when we discuss HELP syndrome, that's kind of a way to think about it. It not only is its acronym name suggestive of hemolysis, elevated liver enzymes, and low platelets, but it's literally all the things. It's the most severe road at the end of this spectrum from gestational hypertension, preeclampsia without severe features, with severe features, and then HELP syndrome. Okay, but having symptoms, say, of new onset headache that's not responsive to Tylenol or visual disturbances, that's why you always ask your patients, are you having vision changes? Do you have headache? Do you have this? Because those are severe features in and of themselves. Though I'll tell you, to have a mild range blood pressure and only symptoms and everything else is negative, it wouldn't necessarily grant you the diagnosis of preeclampsia with severe features, okay? You would really need something else, but these are things to keep in mind, okay? So preeclampsia with severe features and preeclampsia without severe features, they're called preeclampsia for a reason. They are preludes to eclampsia, and as such, each of those has a risk of developing eclampsia, okay? Preeclampsia without severe features can manifest into eclampsia in that in the same logic that I told you, but it can be that you can still have a seizure even when at the time was diagnosed without severe features, right? Um, the the understanding is that at some point it went to with severe features and you missed it, but generally the figure that they kind of, uh, I mean, they that from epidemiological studies is that if you have a preeclampsia without severe features, the risk of seizing is about 1 in 100. Preeclampsia with severe features, the risk of seizing without prophylaxis is 1 in 30 patients. So it's higher. That's why patients are more aggressively treated. You'll find institutions that give it magnesium sulfate to all preeclampsia without severe features. And I'm pretty sure that the the authors of up-to-date articles on this subject actually say, well, we give magnesium to all of our preeclampsia without severe features patients, and that's because there's a risk of seizing. It's not as much, but it is a possibility. At this stage of the game, for everybody in the clerkship, I would just focus that preeclampsia with severe features is the clinical scenario where you will administer magnesium sulfate IV for seizure prophylaxis, and that's standard and what you should remember for your clinical encounters and also for your examination purposes. But I mention it only because if you see a provider somewhere along the line who's giving magnesium sulfate to someone who has preeclampsia without severe features, it's not like a terrible break from standard of care. But eclampsia is when you have all the criteria I mentioned before for preeclampsia, but now you have manifestation of convulsive, usually a tonic-clonic sort of seizure. Okay. You also want to make sure that a patient who presents with seizures and is pregnant also doesn't have a known seizure disorder, because sometimes that happens, or they have recent drug use. You want to make sure that that's not the case. Generally, it's pretty obvious. If you have a patient who's in the prenatal clinic and otherwise you know her history, and she doesn't have a history of seizure disorders and everything else, she has gestational pregnancy-induced hypertension, develops preeclampsia with severe features, presents with a seizure, eclampsia, then you make that diagnosis. The treatment that we'll get into for eclampsia is one to stabilize the maternal patient. Okay, so break the seizures, and that involves administering a benzodiazepine medicine like diazepam or Ativan or whatever it is you have. Here we have Ativan in our Pyxis. And then once you do that, you have to administer magnesium sulfate for seizure prophylaxis. Once mom is stable from a seizure standpoint, you want to expedite delivery, meaning that usually a cesarean delivery, but depending on what stage you're at. Okay? But treatment will follow. So that's, I'll talk about chronic hypertension next, but the final road in your pregnancy-induced hypertension is HELP syndrome, okay? I already mentioned it a little bit, but we'll get into the specifics. So HELP syndrome, the name helps you, of course. It's called hemolysis, elevated liver enzymes, and low platelet count, okay? Remember, your elevated liver enzymes and your low platelet count in and of themselves were severe features, but HELP syndrome is thought of a more severe form of preeclampsia, and it also has an increased rate of maternal morbidity and mortality. And As you can imagine, it's because all of these things are happening. Uh, your liver function tests for your elevated liver enzymes, your AST, ALT, are elevated more than twice the upper limit of normal, as we had said for preeclampsia with severe features. You could have, an elevated, you'll have it in the double digits, but in HELP syndrome, you could have it in the hundreds or even the thousands. So it's quite impressive. That and the platelet count, usually it'll drop less than 100, but it can be very low. It could be, I've seen it as low as 40s with HELP syndrome. Also, part of the definition now is lactate dehydrogenase as a marker of hemolysis. Usually they say 600 or more, but the thing with lactate dehydrogenase is that you're never going to make any decisions management-wise based upon the LDH level. It's something that you get as part of your evaluation, but it's not necessarily the ones you act on as opposed to the AST and ALT and the platelets. And that's more like just like a practice thing. There's really not a good reason for that. This brings up the case where, say you're on the floors, the labor floor, and someone says, "Oh, did you draw preeclampsia labs?" Or we're going to draw preeclampsia labs. What are preeclampsia labs? Well, the preeclampsia labs are the labs that are going to look for these abnormalities. So you're going to get a CBC, okay? Because there you're looking for what? Looking for your platelets, really? That's pretty much it. Then platelets. And then you're going to get a comprehensive metabolic panel. And what does that show you? That shows you AST, ALT, because the comprehensive one includes the LFTs. It includes your creatinine, right? Also, we'll give you a glucose level, which will become important when we talk about acute fatty liver. So that's really important for that. The next things you would get would be, like for example, when I ask for them, I get an LDH level. LDH, CBC, CMP, you're going to get some sort of evaluation for proteinuria, ideally a pre-C ratio, okay? And then the only other thing that sometimes people will get is called uric acid. Uric acid used to be part of the diagnosis of preeclampsia. The idea being that uric acid should be in a pregnant patient should be about 4 because of the increased filtration that happens in pregnancy. So if your uric acid is elevated, that means that something's going on with the kidney. Now, the kidney dysfunction is most reliably measured by the creatinine level, but that creatinine being greater than 1.1. But uric acid used to be part of it, and I also kind of look at it mainly to trend the values, not necessarily make the diagnosis. And that's what LDH and uric acid are primarily for, is to trend the values of these things. Okay, so like I mentioned, the main presenting symptom of HELP syndrome is right upper quadrant pain. It is 100% true. And because of this glistening capsule, which sometimes I ask you about, that's why I mention it. And that's your spectrum. Now we mentioned here your gestational hypertension to preeclampsia to eclampsia, and then eclampsia is you can get to gestational hypertension, preeclampsia without severe features, then with severe features, and then that will go to HELP syndrome. Okay, all along this way you can have seizures. Okay, not really with gestational hypertension, but any of these you can have seizure activity. So really it's just like this is the 1, this is 2, 3 is with, 4 is HELP syndrome, and then all the while you can always get eclampsia. Okay, so that's your spectrum from mild to severe. Now, chronic hypertension, and when I send these slides out, I'll organize them a bit in the more logical format. But chronic hypertension, like I mentioned, is uh, it's pre-pregnancy hypertension, basically. Kind of like you get pre-gestational diabetes. This happens before 20 weeks of gestation. And this is if you have hypertension that's first diagnosed in the pregnancy, uh, and then it doesn't resolve in the postpartum period, that's usually how you make your diagnosis of chronic hypertension. But if you don't have follow-up with the patient in the past, if a patient has hypertension before 20 weeks gestational age, they have pre-existing hypertension or essential hypertension, right? Um, and then that's managed with certain medications, but really it doesn't pose the risks of progressing to HELP syndrome like preeclampsia with severe features or gestational hypertension. So that's why it's not managed as aggressively, okay? That's the important distinction. The distinction being that you don't have to manage it as aggressively because it's not going to progress to HELP syndrome, for example. Okay. Okay, so now let's talk about acute fatty liver disease. So acute fatty liver disease is something that is separate from the pregnancy-induced hypertension spectrum. It is an obstetric emergency um, manifested by acute liver dysfunction and really failure that can have severe morbidity, but it also has a mortality rate. Okay, that's actually pretty different from all of these other processes. While they're severe, they don't usually um, have an increased risk of maternal death. Okay, um, while the initial symptoms are kind of vague and nonspecific, if these patients look very, very sick. Okay, if you've ever seen it, it's very impressive and it's an emergency. Truly, they can have hypertension. Usually, they have proteinuria, but not necessarily. But they have liver dysfunction, as you might imagine, but the AST and ALT is in the 5 to 10 times the upper limit of normal. You could have it there. They're always in the thousands. Okay, the AST ALT. What is and they'll have all the severe features. They'll have the low platelets. They'll have they'll have the liver dysfunction. But what is separate in terms of the diagnosis to say as if it's not just really bad HELP syndrome is that they'll have laboratory abnormalities which are indicative of liver dysfunction. That being low glucose is a big one, and they'll have uh, coagulation factor problems. So they'll have a prolonged PT, INR, and PTT. That's not a feature of any of the other hypertensive disorders. Okay, if you get coags and they're all abnormal, and you got your CMP and your glucose is low, and you have a really sick patient, besides expediting her for immediate delivery in the context of just her clinical presentation, you know that this is what you're dealing with. And the primary treatment is delivery of the fetus, and then supportive care. Um, there's no other treatment that you're going to administer at that time. And then with supportive care and delivery, it will resolve because it is a pregnancy related um, condition. Um, they used to make this diagnosis in the past by doing like a liver biopsy. They don't really do that anymore because nor is imaging really part of this. It's usually based upon if you have these lab abnormalities in this presentation, that's the presumptive diagnosis. Okay. So know these definitions. It's very important in terms of a lot of your questions it's very easy to test on this. So they'll give you the lab values and they'll give you the blood pressure ranges, and that they'll say, all right, well, they probably won't say what their diagnosis. They'll say, well, what are you going to do about it? And we'll talk about what treatments are appropriate for each of these conditions. It may not be obvious to you at this juncture, but not all of these require an antihypertensive, and that's also something to keep in mind. and I'll describe why that is. This is a chart that you don't need to memorize, but it will help you understand the nuances between HELP syndrome, preeclampsia with severe features, and acute fatty liver disease of pregnancy. Okay. Um, I highlighted the important things, but these are just other nuances that will help you to understand what the differences are. I would recommend reading it, but I wouldn't memorize this chart. It's a bit more than you need to know. What I mentioned in the lecture already is what you need to know. So let's talk about treatments. Pharmacotherapy is really the mainstay for this. There's no, uh, uh, like, say, surgical or manual maneuver that you could do to help with this, um, apart from delivery of the fetus to resolve the insult that's causing all of this, which is not the fetus per se, but it's the placenta, right? So aspirin is used in the context of prevention of uh, development of hypertensive disorders in pregnancy. So in patients that are moderate to high risk of developing preeclampsia, um, a low dose aspirin is recommended. Okay. So, but you can appreciate if you look at the moderate risk factors, um, age greater than 35, African American race, low socioeconomic status, history, obesity. I mean, this is like the majority of our patients here at this clinical site. Nulliparity. So, I mean, most patients rule in for at least a moderate risk, which means they're going to get a low dose aspirin. Okay. And obviously, a high risk patient, if they have multifetal gestation, if they have chronic hypertension, because they're set up for preeclampsia with superimposed preeclampsia, diabetes, things like this, certainly do it. And that's something that starts around 12 weeks gestational age. Okay. But that's for prevention. Uh, in terms of medications that you actually will administer for a therapeutic basis, you're dealing with primarily antihypertensive medicines. Your other sort of medicines that are used for the treatment of preeclampsia or really severe hypertensive disorders of pregnancy, then are think prophylaxis for other things like seizure development, which I'll explain. But oral antihypertensive uh, are have a role really in three specific scenarios. Okay. To mention it directly, gestational hypertension doesn't actually require any antihypertensive treatment. Okay. Because gestational hypertension, by definition, presents with blood pressures in the mild range and no other abnormalities. Gestational hypertension is not treated with antihypertensives because we don't want to mask the development of severe hypertension in the context of, say, uh, preeclampsia with severe features. If you have gestational hypertension and then over the course of your pregnancy or the remaining part of your pregnancy, you then develop severe range blood pressures. It's important to know that because that requires prompt induction of labor. If I'm giving you an oral antihypertensive, like the ones I'll describe here, then I may miss the fact that you're having severe hypertension, but while that helps from a hypertensive standpoint, remember the pathophysiology of preeclampsia, you're still having that exposure of whatever that sort of toxin or mediator is. So you're still at risk for seizure. You're still at risk for end organ damage. And because I'm masking your hypertension, I don't see it. So I'm going to miss a diagnosis, and then you could potentially end up with a bad complication and a seizure. So gestational hypertension is not treated with oral antihypertensives. Okay. And then by definition, if you get severe hypertension, well, yeah, then you could treat it with certain medicines, but then it's no longer gestational hypertension. All right. So, but oral antihypertensives are used in the context if you have a diagnosis of preeclampsia without severe features. Okay. So you have mild range blood pressures and you've made a diagnosis of preeclampsia without severe features before 37 weeks, because you want to keep those patients pregnant until at least 37 weeks gestational age when you could induce them. But because you've already made a diagnosis of preeclampsia without severe features, where you have mild range blood pressures and proteinuria, you can give oral antihypertensive to manage that blood pressure because you already have a diagnosis of preeclampsia. So now you're going to follow that patient and trend their lab values every so often, depending on the provider. But you can give these things. And then also, you can give oral antihypertensives um, in the postpartum period. Okay. So either you have a diagnosis of any of the pregnancy-induced hypertensive disorders, but the patient has now delivered and say she's having still having mild range blood pressures or even severe range blood pressures. Severe range blood pressures requires IV antihypertensive because you need immediate lowering of the blood pressure. But for maintenance, in the postpartum period, you can give an oral antihypertensive, okay? So keep that in mind as we describe what medicines you can use, but know that those are the context in which you actually would use an oral antihypertensive. So really, the most common medicines that are used are beta blockers, which includes labetalol for us, and calcium channel blockers, which for us includes nifedipine. I have ER, which is extended release. Okay, dosage is generally not important for you guys at this stage, but we use nifedipine immediate release formulation for a different purpose, which I'll explain. So extended release nifedipine is the oral antihypertensive that's used in the context of managing blood pressures from a maintenance standpoint. We'll discuss other things you can use but are not commonly used, such as alpha-2 agonists, which is clonidine and methyldopa, and then other medicines, including thiazide diuretics, we'll talk a little bit about, and then the medicines that are contraindicated in pregnancy. Pharmacology is always a wonderful thing that you are tested on because it's practical, it has a mechanism, and it's just easy to test. So it's something to keep to your mind. And then also, from a practical standpoint, you'll see that this is what we give our patients, and you'll know why. So labetalol is our beta blocker of choice in pregnancy. It has both alpha and beta adrenergic blocking activity. It's popular because in the first studies in experimental models, it was suggested that it may preserve uteral placental blood flow to a greater extent than other beta blockers. But generally, it's because this has been tested in pregnancy, used in pregnancy. It has a confidence that we know it's reasonably safe. So this is what we're going to continue to use. Beta blockers, they're usually avoided in patients with asthma because it could precipitate bronchospasm. So if you're a patient with asthma, you're not going to go use labetalol as your oral antihypertensive of choice. When we talk about the IV antihypertensive, labetalol is also one of those options. So you're going to avoid it in asthmatics as well. So if you remember from your postpartum hemorrhage lecture, if you have if you have a patient who has asthma, then you can't use what uterotonic? Yep, carboprost, which is tritium hemabate. So you would avoid that, and also if they develop hypertension, you avoid labetalol. So asthma is no a challenge. The other medicine that's used, and actually, really, I think the one that's probably the best to use is extended release nifedipine. Really, no side effects. Significant side effects encountered with nifedipine, like amlodipine, which is usually is widely used in non-pregnant patients. The most common side effect is actually edema. So and you really don't even see that with the pregnant patient because they already sort of have a little bit of an edema. But amlodipine is used a lot in the non-pregnant patient, but there's not really a lot of use for it in pregnancy. So for us, we kind of stick with this. If you use amlodipine in pregnancy, it'll probably be fine, but it's just not as well studied, and really there's no reason to because we know this one works. The good thing about the practical thing about extended release nifedipine is that it's a daily dosing of medicine, and this is a Q8 medicine. Okay, so from a compliance standpoint, this is actually very helpful. Um, Now, I mentioned that I emphasize extended release because your immediate release nifedipine is actually used almost like an IV push. So, um, with calcium channel blockers, the medicine that's most widely used is extended release nifedipine, and while it's similar to amlodipine in its mechanism of action, uh, nifedipine is most widely studied in pregnancy. Okay, amlodipine I know that is used a lot on the outpatient side in non-pregnant patients, um, but for us in obstetrics, we usually stick to the to nifedipine. The most common side effect of amlodipine really is just like edema, but even that we don't really see with nifedipine, probably just because pregnant women have a certain amount of edema anyway, so maybe it doesn't bother them. But this is a safe medicine, and it's something that's most widely used, and really it's probably the best choice in all of this. This is different. The extended release formulation is different from your immediate release medicine, as I described, because the immediate release formulation of nifedipine is used for two purposes. It's used for acute drop in blood pressure, which you'll use for your IV antihypertensive. So it's a really good choice for patients who have severe range blood pressure that you need to immediately lower, but don't have, say, IV access or have poor IV access. This can work almost like a push for you. And also then in the context of tocolysis uh, um, in the setting of preterm labor, okay? So preterm labor, less than 34 weeks gestational age, tocolysis is part of the management for what purpose? That purpose is to delay preterm labor because you're not really going to end it, but you could delay it in as long as you can get your full course of corticosteroids on board, which is a 48-hour process. You give the one dose of the 12 milligrams of betamethasone, and then you repeat it in 24 hours. Okay. Um, Tocolysis also is a term that we've used in a prior lecture when talking about uterine tachysystole and as a cause of fetal distress, where in that situation you are still requiring tocolysis, but you're using the medicine terbutaline instead. Okay, so get that straight in your head in terms of tocolysis, because really that's the only context for um, tocolysis. It's either you're trying to prevent preterm labor to get corticosteroids on board using nifedipine immediate release, or if you have uterine tachysystole for a pregnant in labor, a patient in labor, you're going to use terbutaline to relax the uterus and allow the fetus to recover. Okay. In addition to the effectiveness of nifedipine, it's also a daily medicine, so it's administered daily, as opposed to your beta blocker, which is an every 8-hour medicine. So you can imagine that compliance is also better with this. So this is why it's generally a good choice as maintenance for hypertensive disorders. Other options that exist but aren't usually used, you have the medicine methyl-dopa, which is an alpha-2 agonist. It's a mild antihypertensive agent, and while it was traditionally used because of its long-term safety profile for the fetus. Um, because it's such a mild medicine, many women they don't achieve their blood pressure goals, and the more you increase your dosing of methyl dopa because it's related to dopamine, you get a sedative side effect. So it's something that's largely fallen out of favor. But occasionally you may see older physicians use it, or even patients that are very low risk, which is hard for me to imagine just because our patients are so not like that at this site. But if you see it along the way in other places, then you know that this is an option. And also, alpha 2 agonists that you can use are clonidine. Clonidine is actually something that you'll see used a lot in psychiatric disorders. Even like if you're on your pediatrics rotation, clonidine is used for ADHD, and then also clonidine, and then its associated class of medicine, the alpha 1 antagonists like prazosin are actually used for things like PTSD and stuff. So it's actually pretty interesting because it works as a blood pressure medicine, but it acts centrally. But clonidine especially, it has a bothersome side effect of rebound hypertension. So if you have a patient on this medicine as maintenance and then they suddenly come off of it, it has this side effect, which is kind of difficult to deal with. It works as an antihypertensive, but really it's for patients who otherwise cannot take nifedipine or labetalol. And what's also helpful is if there's some reason, some issue with taking pills for whatever reason, it could come as a patch, which is helpful. So then that might be an option. If you have a patient who has some psychiatric disorder and also is pregnant, well, this actually may be a good option for them. You can keep it on maintenance in the long-term part of their pregnancy. So that's a consideration as well. For medicines that are straight up contraindicated, your ACE inhibitors, ARBs, direct renin inhibitors, and really they're contraindicated for the very mechanism of their action and that it causes renal problems. That's what these things do, this class of medicines. But more than that, the renal problems exist in the later half of pregnancy. In the first trimester, these are associated with your classic sort of teratogenic effects like cardiovascular and central nervous system malformations. So we don't use them. In terms of other medicines you might see, like spironolactone and eplerenone, they really haven't studied them because they've always tried to avoid their use, and also their use in pregnancy has never really been required because there's been other alternatives. But an example that's pretty interesting is like eplerenone, for example, is used in this this rare disorder where there's a problem with the sodium channels and leading to a hyperaldosteronism or Little syndrome. They've used these class of medicines, and it actually had fine. The cases were okay, but this is only because they had to. But generally, when you're talking about hypertensive disorders in pregnancy, these are not part of the management. If you have to use them, it's kind of very on a individual basis, and certainly nothing you're going to be tested about. Thiazide diuretics are not really used. It's not that they're contraindicated, but they affect the volume, right? That's kind of the point of them. They affect the kidney, the filtration system, not the kidney parenchyma itself, with the loops. I mean the filtering system. It's not a loop diuretic, but you're also kind of worried about volume depletion and like the shifts in pregnancy anyway. Some people use them, other people don't. Generally, they're not used in women with hypertensive disorders like at all. So most certainly preeclampsia because you're concerned about that. But it's not that they're contraindicated. So I just wanted to mention that. Don't put too much thought into this. It's more of a discussion. So those are your options. Really, for your oral antihypertensives, remember your beta blocker, remember your calcium channel blockers. Remember labetalol, remember nifedipine, extended release. Generally, when you're in your clinical modules here, this is the medicine that is encouraged for all the reasons I just mentioned. Okay. When you have severe hypertension, however, you have to use IV antihypertensives because you need immediate lowering of the blood pressure, not to normotensive range, but to mild range at the very least. Okay. Persistent severe range blood pressures is never acceptable. Say if you identify a patient, she has severe range blood pressures, you repeat it in 15 minutes, and it's still high in the severe range, you got to give a medicine to lower it. Okay. And if that consists, if you are persistent in your medications and it's still not lowered, well, apart from immediate delivery, then you have to get your consultation with your ICU to figure out what's going on. Something I'll mention to avoid confusion. If you have preeclampsia with severe features, that doesn't require a C-section, okay? That requires induction of labor if you're above 34 weeks. But you can manage them with these IV and oral antihypertensives and then seizure prophylaxis, which I'll explain. But you could give them start an induction of labor and allow them to have a vaginal delivery. That's fine as long as everything is well controlled. If you progress to HELP syndrome, for example, and you can't get adequate control and there's worsening, well, then that requires an immediate delivery, usually by cesarean delivery, because patients will not be in a position where they could do, say, an operative delivery. They're not progressed that far in pregnancy. So just keep that in the back of your mind. In terms of IV antihypertensive, you can use labetalol. Your peripheral your peripherally acting antihypertensive is hydralazine that you can use, and then immediate release nifedipine, which I think I've kind of harped on a lot. Labetalol is the same situation like we discussed. You want to avoid in women with asthma. Hydralazine is it generally doesn't present with really any side effects. I mean, if you they say it can be linked with maternal hypotension or fetal heart rate tracing abnormalities, but anecdotally, I'll tell you that this medicine really is very well tolerated and there's really no side effects. Hydralazine, I know for like rheumatologic disorders and things like that, sometimes they say that you get like a lupus-like syndrome. That's something we don't see and really I've never seen. So it's a little bit different in our patient population, but hydralazine is also a really good option because it's sort of like nifedipine extended release in that way. And that's sort of not a shock because the mechanism of hydralazine is it works peripherally on the blood vessels. The calcium channel blockers kind of do the same thing. Anecdotally, it seems like that mechanism seems to be very favorable in these disorders. But as it stands currently, any of these is an acceptable option. Okay. Here's an example of certain algorithms, the way that you can manage these, how you use to lower severe hypertension. You do not need to memorize this, but just like when you see this happen in your on the floors in your clinical module, which you certainly will see hypertensive disorders in pregnancy in this module. Um, this is just how it works. This comes from ACOG District 2, which includes New York and a couple of other states. Okay. Um, Hydralazine is the same way. The only difference really is that labetalol, you actually wait 10 minutes to repeat the BP, and then hydralazine, you wait 20 minutes. Okay, and the dosing is a little different. Same thing with nifedipine, immediate release. Um, take a look at those just for your FYI, but this is not anything that's really high yield in terms of it's high yield in terms if you go into OBGYN as a residency, but it's not high yield if you for your shelf exams and things. Know the other things that I mentioned. So I mentioned this a lot, seizure treatment and prevention. It's pretty straightforward. Magnesium sulfate is it's used for seizure prophylaxis. There was a time where they thought maybe it's used for antihypertensive agent. It's not. Um, it's used for only in the context of seizure prophylaxis. Also, something that it used to be used for is for tocolysis as well, actually. Just because the general gist of how magnesium sulfate works is it relaxes the tissues, right? Because it works on the membrane channels. So that's why you can have this concern of higher doses of magnesium sulfate. You can have things like respiratory depression, or it actually will lead to some level of tocolysis as well, only because it's relaxing that uterine muscle. But it's not as reliable, so it's not used for that purpose. So that is an effect you'll observe. And then for seizure prophylaxis, it lowers the threshold of seizure activity in the brain, but also you want to think of it kind of like it's relaxing it a little bit because that's really the overall gist of it. So contraindications to seizure prophylaxis are pulmonary edema. Now, pulmonary edema is not caused by magnesium sulfate. Okay, that's important to know. If you have pulmonary edema develop, which is a consequence of preeclampsia with severe features, then magnesium is contraindicated. That's what you're looking for, you know? So, but it's not that MAG is causing the pulmonary edema. That's a common misconception, okay? If you have renal failure, you can't use MAG. If you have like a creatinine that's 1.1 and you diagnose preeclampsia with severe features, that's renal dysfunction, but that doesn't preclude you from using magnesium sulfate. I'm talking about like you have legit renal failure. Like your creatinine's like 4 or something. That's and then myasthenia gravis as well, because you already have those channels are impaired. If you add something additionally, it's going to cause cardiac problems and etc. So magnesium sulfate is for seizure prophylaxis, okay? Now, if you have a seizure develop, you have eclampsia, you give MAG to prevent recurrent seizures, okay? But you have to treat that seizure. And the way you treat it is to break the seizure is like any other seizure. You use a benzodiazepine. So you can use diazepam, lorazepam, Ativan, whatever you want. Um, if MAG is contraindicated, it's not like you just give up and you don't have any seizure prophylaxis at all. Use levetiracetam, which is Keppra, um, for prophylaxis, but also then you could also treat seizures with this medicine. Keppra, I feel like, is used for pretty much any seizure disorder that I've ever encountered for a pregnant patient or even a non-pregnant patient. It's a very good medicine. It works, and there's a lot of trust in it in the neurology community. So Keppra is a really good option. And if you have a patient who has a pre-existing seizure disorder, they will most certainly be on Keppra unless there's a problem, an allergy or something to it. Okay, so to be familiar with this medicine in general is it's a high yield thing. So mag toxicity is something that we look for if you have a patient who's on mag sulfate drip in the context of preeclampsia. Then you're going to be doing your what's the quote unquote neuro checks about every 4 to 6 hours, depending on your institution. And what you're looking for is magnesium toxicity. The way you do that is you do your lungs and reflexes, right? Because you're looking for loss of patellar reflexes and you're looking for respiratory paralysis or sluggishness. If you could appreciate, you got to be at a pretty high level. You got to be greater than 7 to lose your patellar reflexes, and you got to be greater than 10 uh, to lose your um, to cause respiratory paralysis. And then really, if you get cardiac arrest, you have to be pretty high. There has to be pretty gross negligence to prevent that. Your therapeutic range is 4.8 to 8.4. Okay. So anywhere in this range is therapeutic. Generally, when you start to get to like 7 or so, there's some concern, so you want to knock it down. And those are the high yield things that are involved in this with the definitions, the treatments, and the context of such. So general recommendations you want to know that I've already sort of mentioned, but I'll go over them again, is that if you have gestational hypertension or preeclampsia without severe features, and you're greater than 37 weeks, delivery is recommended, okay? Usually if you have gestational hypertension, you're going to be induced around 37 weeks in most institutions, okay? These come from ACOG, so the induction recommendations sometimes are a bit broader to apply to everyone across the country. If you have severe features, induction is started earlier, 34 weeks. If you have severe features develop. If you have severe features develop after 34 weeks, whenever you identify them and you make a diagnosis of preeclampsia with severe features, you induce them. Okay. This is a new recommendation that should be highlighted. I kind of mentioned it already, but you shouldn't delay delivery of induction of labor in the context of severe features in the late preterm period. By the late preterm period is greater than 34 weeks. Okay, it's still preterm because the late preterm period is greater than 34 weeks gestation, but it's less than 37. Okay, and that's your window. The point is that if you have a patient, say 35 weeks, and she has this, you induce her, you give her the corticosteroids, but you don't delay the delivery. Okay, so review all of that, and what I will do is the next time we meet, I'm going to have what I'm going to do is the lecture schedule will be the same. I'm going to have a sort of like a question period where I come up with scenarios based upon all we've discussed in the obstetric condition series so far, like the virtual series having to do with obstetric conditions, to make sure we really got it. So review this, and our next discussion will be about the non-pregnant patient. So what's referred to as gynecology, your gynecologic disorders, which is primarily based upon bleeding, abnormal uterine bleeding.